Before VEXAS was described, there were patients who seemed to sit awkwardly inside rheumatology categories without ever fully fitting them. They had refractory inflammation, unusual organ involvement, steroid dependence, cytopenias, and marrow abnormalities. They often moved between specialists, accumulating labels that explained pieces of the picture, but not the picture itself. And then, in 2020, came a genetic signature, somatic mutations in UBA1. Suddenly, what had looked like several different diseases could be understood as manifestations of a single hematoinflammatory syndrome. A new American College of Rheumatology guidance statement, developed by the International VEXAS Working Group Expert Panel, is an effort to bring structure to the evaluation and management of patients with VEXAS. This paper makes recommendations for who should be tested for VEXAS, how this testing should be done, how to interpret bone marrow findings, how to think about treatment in a disease where the evidence base is still very limited, but the clinical stakes are high. My guest today is Dr. Arsène Mekinian. Dr. Mekinian is professor of internal medicine at the Sorbonne Université and a clinician at Hôpital Saint-Antoine in Paris. He has led international collaboration around VEXAS syndrome and is the lead author of these guidelines. Enjoy. Arsène, bienvenue. Welcome to the show.
Hello, thank you very much for the invitation.
We're so excited to have you here and talk about the new ACR guidance statement for the diagnosis and management of VEXAS. VEXAS is a very recently described condition, right? I think that New England Journal article was in 2020, and it's actually pretty quickly that the ACR started developing these guidance statements. Why did you feel that the field was ready to have this guidance statement right now in 2026?
You know, the history of this disease is that we and several ones had not so much of medical doctors were very interested in different immune features or associated to hematological disease like myelodysplastic syndrome. But we were a little in the difficulty because we don't have a real signature, genetic signature. So when David Bake, for those who know, of course, which is who describes this UBA1 mutation, when he described this mutation, this was really like a revolution in the very small field of this disease, because this is the first time we have really a genetic signature. So we all each know each other's, but this was really the reason to join our efforts. And I was one of those who a lot worked for this with David, because we considered that we can really start anything with this disease, which was really, described very clearly, and so we can really start to work. And this was a very kind adventure for this. So this is a little history about this.
Amazing. So this statement was developed by the International VEXAS Working Group Expert Panel. So what kind of physicians made up this panel, and why was that important to have a wide variety of doctors involved in this project?
We were few at the beginning because here in France, we have a very organized network which is Minemon, which I founded more than 15 years before, and which is also actually included FriendVex. So we have a very organized network. But when we discussed with David, with other colleagues, we decided to do two things. We decided to start the international annual meetings, which is a VEXAS workshop. The first one was in Paris. The second one is in New York. And in September, we will have the third one in Milan. And the second point was to consider which people from different countries, even those who don't really, for the moment, have really diagnosed VEXAS, but we are interested in these diseases which are between hematology and rheumatology, internal medicine. So I was one of those who a lot walked in the world, proposed to the scientific committee, and after we contacted everybody, and we organized a group, which is just initially a group of people who were interested to work together on this exciting new disease.
Yeah, I mean, it's amazing. And I think the group It's certainly really international and made up of like rheumatologists and hematologists, dermatologists, pathologists, geneticists. It's really awesome that all of you came together to develop these guidance statements. It's interesting that there's very little evidence upon which the guidance statement was founded, right? Like, we don't have very many clinical trials to sort of suggest, like, oh, these are definite recommendations. How did you guys manage those shortcomings that there just isn't that much data available about how best to
Yeah.
treat these patients?
Yeah, you have right, of course. It was really very, very, very unusual. We don't do it usually, of course. It's usually experts which have several years experience, trials, courts. So it's really, of course, very, very unusual, as you said. But we all agreed that we would like to start anything with these first common criteria, which is really a common effort to do a work together. I think it's a very, very important point. Actually, in medicine, we have all very, very fields which are extremely specialized. And probably this is anything which is very interesting just to consider, because we really work together and really have a lot of interactions which are interesting for all of us. So this is just as always a human adventure. We really decide that we can do statements which are for the moment the consideration of how we do it in different countries, because there are real differences, how we manage this disease in countries, even in considering people who don't have this experience, because at this time our friends from some countries even don't have the UBAM1 mutation screening tools. But
Wow.
we consider that it's not a problem. They have also their experience, which is interesting, because how manage people you suspect a disease but you don't have the definite diagnosis. So I think that it's very, very important to consider this kind of groups. And of course, we will evaluate progressively in 2, 3, 4 years when we will have some trials. We will, of course, reconsider the statements. And in the time between, we have opportunity to be all together for all trials which are actually ongoing in the international level. This workshop, we are all inside. So this is, I think, really important to start to work all together this kind.
Yeah, I mean, I really value the work that you've done, because you're right. Like, we're seeing these patients in our clinics and we need some guidance as to like how to diagnose them, how to treat them. So for me, it was really helpful to have to look at this data and sort of try to figure out who in my panel may have VEXAS and how to think about treating them. So for the practicing rheumatologist out there, what are the clinical features that should trigger the suspicion of VEXAS? I think that's one of the most important things that this paper brought home, is like, in whom should we consider this diagnosis of VEXAS?
The most important to begin, which we have to say, is that the VEXAS, as it was described by David Beck, and actually, of course, we have a lot of works which really expanded the clinical spectrum of this disease. So the first we always say is that we have really to be humble, extremely humble, because we don't know probably all clinical features of this disease. At this moment, we also discover VEXAS patients which have no inflammation, so which was really extremely unusual at the time we describe it. And so the first point is, globally, you have to consider a VEXAS disease, or more globally, myelodysplasic or hematological associated disease, when you have a usual outcome of your usually idiopathic disease. So when you have some patients which have a giant cell arthritis, polyarthritis nodosa, rheumatological disease, spondyloarthritis, we have a skin disease. And of course, when you have patients which have several unusual presentations, for instance, in giant cell arthritis, you don't have usually skin or lung disease. For instance, in polyarthritis nodosa, you don't have always some disease. And so you have to consider. And the second very important probably message for all of us is that we have really to consider the numeration. You have to see if there is some cytopenia, macrocytosis, etc., because this is another very, very important point. When you have cytopenia, macrocystic anemia, you have really to consider that you can have, of course, associated VEXAS or myelodysplasia syndrome. So,
Yeah, I think that's huge. I had a patient who had just very refractory inflammatory eye disease, right? And just required steroids over and over again. A little bit of anemia turned out to have VEXAS syndrome. So I think, yeah, like you said, unusual manifestations of GCA or rheumatic diseases, refractory disease, like you mentioned, cytopenias, macrocytosis. I think that these are all great. I think also in your paper, you emphasize that it's certainly the pretest probability is higher for males than with females, and then patients generally older than 50 years, and when acute phase reactants are elevated. Although, as you said, we should remain humble because I think in the paper you mentioned that there's been patients as young as 20 been diagnosed with VEXAS and even in women. So how should we think about that, sort of the demographics? I guess older male is the one that we should have the highest degree of suspicion, right?
Yeah, of course, it's important to consider the patient's sex, but we also have it actually in women. And also we have it in people which are youngest. So of course we don't have to consider for the moment in 20 years old patients, which is female, but globally, when you have really unusual disease for the clinical presentation, for the outcomes, steroid refractoriness or dependence, really we have a usual diagnosis which we consider. And in this diagnosis, we usually consider the globally paraneoplastic diagnosis, which is associated with neoplasia, hematological disease. And so just VEXAS is another important consideration which have to be considered in these patients. And more importantly, probably in the future, that we will be more and more to consider even patients in refractory disease, which is already a little the case of giant cell arthritis, just with association with hematological chip, so hematological mutations without clinical significance. So it's really a new area because in this area we really have to consider all this hematopoiesis of determined insignificancy. It could be VEXAS, it could be just some mutations, like real association with a not usual outcome of our disease and presentation.
Great. Before we get to testing, can you talk a little bit about this? VEXAS is sort of developed through somatic mutations. Can you talk? Do you have any insights about why that may happen and some challenges that presents the fact that it's a somatic mutation as compared to sort of germline mutations that we most commonly think about?
Yeah, of course, usually we consider that it doesn't exist when at the birth, so it's not constitutional. It's acquired mutation. But we don't know for the moment how time is necessary to develop the clinical disease in patients with this kind of mutation. For instance, we have a very interesting patient with one of my friends, hematologist Pierre Hirsch, when it was really just a thrombocytopenia, essentially thrombocytopenia. It was very easy to treat. And 3 years after, it developed really VEXAS syndrome. So it was diagnosed. When we considered all previous genetic screening, we discovered that at the time of the thrombocytopenia, which is really very isolated, which is absolutely unusual for VEXAS because the thrombocytosis is usually never seen, patients have already a very, very small quantification of UBA1. And it was absolutely in 2 years dramatically increased and even make it disappear the calreticulin mutations and other mutations. So for the moment, we don't know the real dynamic of this clonal disease, but we probably can consider that it can be several years before. So, but for the moment, we don't know really how it appear and how is it for important the mutation importance quantifications or not. But we will know it in a few months very very clearly.
Great. And then, so how does that affect genetic testing, right? So the fact that you have the mutation only in a subset of cells makes it more challenging to diagnose. So how should, for rheumatologists that are considering VEXAS syndrome in one of their patients, how should we think about testing for the mutation?
The testing actually is very, very easy in Europe, in just industrial countries. So we have even the testing, which is included in the global myeloid NGS, which is considering all somatic myeloid mutations of those of myelodysplasic syndrome, UBA1, etc. So usually it can be done even in the blood if we don't have a to go to the bone marrow aspiration. So it's really very easy in more of the industrial countries. It's a little more difficult for the moment in some countries like our African colleagues, even
Mm.
some countries from Europe, some countries from, of course, some regions, when you can consider Singer, which is also very easy to do the diagnosis, but actually, really, we have it on the NGS.
Okay, great. And are there like mutation negative patients, or how should you think about in a patient that you highly suspect VEXAS, but the traditional testing is negative?
So these patients are, of course, of high interest for the moment in very big groups which are working on this. It's what we call the VEXAS-like disease. So when really patient is clinically very and biologically very, very suspected, but we don't find the mutation. So usually, of course, we go, for the moment, of course, we have studies in scientific labs. So of course, we collaborate with, but globally, we go to more important genetic screenings when it's available, exome, genome, etc., when we can find it. But it's not so clear for the moment for this specific situation. So in the future statements, we will probably be more clear on these very, very particular patients.
Okay, great. And tell me a little bit about you've spoken a lot about the cytopenias. So sometimes these patients get to hematology and oncology before they get to us. So what is the role of bone marrow biopsies for these patients? Should every patient with VEXAS have a bone marrow biopsy? Should every patient be referred to a hematologist? Or how should we think about what's happening in the bone marrow?
The bone marrow for us is to diagnose the hematological part of VEXAS. So usually we consider that at least anything is not normal. At least one thing is not normal in bone
Mm,
marrow aspiration. It can be the presence of dysplasia. It can be the presence of vacuoles. It can be, of course, presence of our features like the absence in sometimes of megakaryocyte or even blast, etc. If we have a myelodysplasic syndrome. So usually we have a an abnormal bone marrow aspiration analysis. But the difficulty, it was a very, very, very long workshop of hematologists for these statements, is how you differentiate the VEXAS syndrome and bone marrow aspiration from the myelodysplasic syndrome. And so,
mm,
which is actually considered to really be more MDS than VEXAS, it's that we can have in both the presence of dysplasia, but the presence of abnormal karyotype, the presence of additional somatic mutation, very useful to really consider probably associated myelodysplastic syndrome. So you can have dysplasia, you can have vacuoles, but it's not considering MDS if you don't have abnormal karyotype or somatic mutation. Of course, it's actual statement. It can be moved, but for the moment, we consider it like that.
okay. And
And it's important because, of course, the prognosis is not the same. In VEXAS, we consider that we don't have a acute myeloid progression, leukemia progression,
mm,
but we can have recurrent cytopenia, but which is not the same. We have, if it's not, of course, MLL, we don't have the usual acute myeloid leukemia treatment, but will have the treatments like VEXAS for refractory cytopenia.
okay. At least, I know that in the rheumatology world, because of the New England Journal paper, podcasts like this, I think VEXAS has really entered all of our minds, and we're all sort of actively looking for VEXAS in patients that are just refractory or have unusual presentations. Do you think the same is being seen by the hematologist, oncologist when they get patients with MDS? Are they also actively considering VEXAS as one of the things that they should be thinking about?
It's really depending on countries and when you have really cooperation between rheumatologists, hematologists. So, but usually you have, of course, difficulties. The main difficulty is really to consider myelodysplasia and or VEXAS, which is really the main difficulty because even hematologist will discover abnormalities. So he will consider that it's hematological
Mm,
disease. He will have a not normal bone marrow aspiration. So the difficulty is real to how it will be managed by the hematologists if you have mainly rheumatological, of course, features.
mm,
Because
okay.
cytopenia are not, of course, very dramatic usually. So they are less hematological than rheumatological disease, usually.
So, what is the natural history of patients with VEXAS? What happens to them over time?
This is not so easy for the moment to clarify, and the different questions is do we have some patients which have aggressive disease? It's probably patients which David Beck described, more hematological patients with more progressive disease, more refractory cytopenia, and these patients usually have a bad outcome, which is mainly because of the presence of different infectious complications related to immunosuppressive therapies, etc. But we also have very probably patients which have a not so bad prognosis, which have a very small doses of steroids or some drugs and don't have so dramatic disease. And you have also patients which are really rheumatological patients, but have very difficulties to have clinical inflammatory remission. So they would be refractory to biotherapies or azacitidine for giant cell-like disease or anything like that. So for the moment, we really work on the markers which could really help us to better stratify the patient's outcome. Is it the difference and increase of VAF quantification with BA1? Is it the enrichment of some new myeloid mutation? Is it the patient's more hematological than rheumatological disease? We don't know these points very, very strongly for the moment.
Mm-hmm. Yeah. Let's shift gears a little bit and talk about treatment. I find it very interesting that in almost every other rheumatic disease, we're trying to wean steroids as much as possible, start DMARDs as soon as possible. Whereas here, it sounds like, it's still first line treatment, according to your algorithm, is start corticosteroids.
The steroids is a very known drug for all this immune disease associated with hematological disease and also oncological disease. So it's not new. We
Mm.
know it very, very long time that steroids are extremely effective, but very, very high level of steroid dependence. So it's really not new. We know it.
Mm-hmm.
Which is really very usual is that DMARDs, even we don't have a so big studies, of course, etc., are really seem to be completely ineffective, really. And this is clearly very interesting to consider because we don't understand why DMARDs are not working, and why biologics like IL-6 and inhibitor and not TNF alpha inhibitor are working, when why JAK inhibitors are working and not DMARDs. So it's really intriguing.
Okay. So I guess, according to these algorithms, you start steroids, and then in patients that require chronic steroids or relapse when steroids are withdrawn, you're recommended to start a steroid sparing agent. Among the agents, you list IL-6 inhibitors, JAK inhibitors, and IL-1 inhibitors. How should we think about choosing one of these for a patient with recently diagnosed VEXAS? Do you think about what manifestations they have and then choose accordingly? Do you go by what comorbidities the patient may have, or do you go by what's simply available to the patient?
It's another very difficult question for the moment because there is several points, important points. First one is that you have very differences between countries. You have countries which don't have some drugs because they cannot use it. Even in industrial countries like Switzerland or Belgium, they cannot use all drugs as we can do it free in France, for instance. Our American friends use more IL-6 receptor inhibitors, for instance, and JAK inhibitors. So it's really because JAK inhibitors were described in France. Our colleagues less believe it, or another less have experience. So there is a lot of heterogeneity, and I don't believe that we can really consider which one is best or not because it's really very depending from the colleagues and countries, etc., and availability of drugs. But usually we consider that we will use more IL-6 in a very systemic disease. Of course, if we already have a giant cell presentation, we will prefer, of course, tocilizumab because we use it usually in AGC, in GCI, sorry. IL-1 is very, very few used in the world. We have the only really very big description, which we done it with our Jewish friends, with Tali. And it is really canakinumab because anakinra is extremely badly tolerated because we have a very, very lot of reactions. So
Hmm.
canakinumab is, of course, very expensive drug, so it's not used very you very frequently, even in France. And in all cases, usually we have some escape in this biological drug. So we use it in some time, but usually, as it's really molecular disease, clonal disease, it's not working usually for a very long time in all cases.
And then I think you list here among the JAK inhibitors that ruxolitinib seems to be more effective than other JAK inhibitors. Do you have any idea why that may be the case?
No, it's not so clear, so I don't know. It's in the data, of course, are interesting, but are not so important to be really, really convinced completely for the moment, because ruxolitinib was a hematological prescription. So of course they more use this drug. So we have more experience with this drug.
Hmm.
Is it really so more effective than others? It seems to be from the first studies, of course, but really we have for the moment the small reports. We have to go we have a more extensive data which will be available very soon, so we will really see how much is it true, of course.
And you mentioned that patients sort of that the drugs seem to lose efficacy. So is it common for patients to start an IL-6 and then move on to a JAK inhibitor and then like an IL-1 inhibitor? Is that what you how you typically manage patients with VEXAS over time?
Yeah, we have patients which start some drugs, and we have initially even sometimes remission,
Hmm.
inflammatory remission, because all these drugs don't allow the molecular response, so don't have any effect on the UBA1, of course. But sometimes we have to move it, and the real challenge is, do we move it to the clonal disease treatment like azacitidine, or do we move to combination of the AZA and IL-6 or IL-1? So we work on all these points. We have studies on the combination therapies. So we will probably have some interesting data in the year, but for the moment we don't know really. So we do it very differently once again from the how were the patients, how is the experience of each group. So very different. Is it hematologist or of course rheumatologist? So really different.
Yeah. Yeah. So let's get to some of those points that you mentioned. So as rheumatologists, we're all familiar with the medicines that we just talked about, the IL-6, the JAK inhibitors, IL-1 inhibitors. But, I think as part of the algorithm, you have patients with more severe hematologic manifestations, with cytopenias, maybe patients that are transfusion dependent, or patients that have developed MDS. You think about other ways of managing and trying to target that UBA1 gene. You seem to have sort of two options. One is stem cell transplant, and then the other one is azacitidine. Can you talk about sort of those two options and when you should consider them for your patients?
So we in France we have a lot of experience with azacitidine because we even do the only for the moment international trial, open label trial. But in this situation, several years before and even before we know really the VEXAS syndrome, and so we have a lot of experience. So azacitidine is very widely used in France, and also because we have national meetings when we discuss cases, so it's a little more homogeneous. But in some countries, you cannot use it. You cannot use it because you don't have a real myelodysplasic syndrome, and in these cases, you are not allowed in some countries' regulations. It's the case of Belgium, for instance, or Switzerland. So you cannot use drug which is not authorized in a very specific situation. For allografts, the situation is very difficult. It's very difficult historically because even in other hematological disease, we know that states in United States, use of allograft, autograft, or allograft is more frequent than it's in France. It's the case, for instance, for amyloid disease. So we have a really different point of views or experience. So this is also the case for VEXAS syndrome. We nearly allograft 1 to 2 patients by year in
Mm.
France. And in America, we have, of course, a very good and the first international open label trial on the benefit of allograft in these patients. So this is really very interesting and important to consider. One, we have to really constitute international groups because our experiences are different, but they could be, of course, complementary because each can, of course, learn from another one and to have some information. But allograft in France is really very, very rarely practiced for the moment. So we don't have a good experience for the moment for
And in
that.
patients that receive stem cell transplant, is that curative?
Yeah, we know it's also for previously. We know that previously all patients, more than well, not all, but a lot of this for patients with myelodysplasic syndrome associated immune disease have a very, very good response, remission, when you, of course, drop out the clonal disease. So it's, of course, also the case of UBA1. We have, of course, some retrospective cohort, which seem to be very interesting. And of course, we know that the clonal targeting is extremely important in this disease, of course.
Mhm.
But it's
Are
not
the,
always necessary. This is an
hmm.
interesting point, which is different when it's really a hematological high level or high risk disease.
And are there thoughts about using CAR T cells in these patients as well?
For the moment, as far as I know, have never been used. We have some B-specific targeting which would be available, but for the moment, I don't know. I don't know the cases about CAR T cell, the use of CAR T cell. In Europe, no, of course, but I don't know if there is some cases available or not. But for the moment, I don't think.
Can you talk a little bit about some of the sort of recommendations? You have a patient with VEXAS, they're on treatment. What sort of prophylaxis should we think about? Any sort of baseline test that we should consider getting at diagnosis?
Yeah, this is another important point we also learned altogether. We learned that the VEXAS syndrome is probably one of the new diagnoses of acquired immune deficiency. So,
Hmm.
for instance, our first case, my personal first is the department was a 70 years patient without any disease. He have never been ill, really ill. He have never drug, and he have been hospitalized in our department for two sequential infections.
Hmm.
One Serratia pneumonia, and about 1 month after, a very severe Legionella
Hmm.
pneumonia. And we really discovered his disease during the hospitalization. And this case was really one of the first, even internationally, which raised the question of VEXAS like really acquired immunodeficiency, not only
Hmm.
rheumatic disease and hematological disease, of course. And after, so French group, so published FriendVex data about our infectious complications, and we also confirmed that not half, but 50% of patients develop infection even without any immunosuppressive drugs. Of course, they have a lot of immune infectious complications when they have immunodeficiency acquired by immunosuppressive therapies, etc. But even without, this can be presented by infections,
Hmm.
repeated and explained infections. So our international recommendation was to be and to use like all hematological patients to use, of course, pneumocystosis, prophylaxia, and Zelytrex, valacyclovir from all herpes group infections. So this is clear recommendation. And of course, vaccinations, and of course, to treat very, very quickly all infection, suspected infection in this patient. So very, very close to do it to we do in all patients with hematological disease.
And who should be involved in the management of patients with VEXAS? Is it sufficient to just be the rheumatologist, or does it depend on what disease manifestations the patient may have?
In international statements, we were very, very comfortable to say that we really need a collaborative interactions, and we need hematologists and specialist of systemic disease, rheumatologist, internal medicine doctor, or any other doctor which is usually locally involved in autoimmune systemic disease, because clearly the facility to quantify the mutation, to see the somatic mutation, to manage the cytopenia is not so easy for everybody which is not hematologist, and very clearly to manage the rheumatic manifestations is not very easy when is not specialist of this kind of disease. And so the collaboration seems to be very, very interesting. And the management of biologics is mainly for the rheumatologist, whereas the management of other CTD and allograft is mainly the hematologist. So really, it was very, very strongly accepted to be really collaborative for the management of these patients.
We talked a little bit about the beginning that there's very little sort of hard and fast evidence to sort of guide treatment decisions on these patients. What do you think after doing this guidance statement? What are the biggest unanswered questions that were brought up after you guys met? And what are the things that the field should be working on over the next few years to try to improve the care for these patients with VEXAS?
There is probably 3 points. Well, we have still really a need to improve the global knowledge of this disease in our not specialized colleagues, friends, because of course for specialists and experts it's very, very easy actually. But
Hmm.
for all our colleagues, pneumologists, dermatologists, even nephrologists, neurologists, even ophthalmologists, all these colleagues which are not very usually see these patients, of course, we really have to improve their knowledge. The second point, very probably, is that we really have to improve the better stratification of these patients. As you know, in all our disease, we have disease activity scores, we have stratification scales, and we know that if in VEXAS it's the same. All patients have not the similar outcome, and we really have to know which one will be severe, which one would be probably less important outcome, and it's important to stratify the treatment and the relapse risk, etc. And of course, the most important point is that we need better treatments. We have better to determine which treatments are really effective, when we have to treat patients, when we have to start treatment patients, when steroids could be even disrupted. So we have a lot, when allograft, of course, have to be done in patients which have only 50 years. What we have to do, we have to go to the allograft transplantation, or we can. So there is a lot of important questions for the moment, of course.
Yeah, Arsene, this has been a wonderful conversation. I think we all need to thank you for leading this expert panel, for developing these guidance statements that will help all of us better recognize and treat patients with VEXAS. And I hope that you continue to work in this field and continue to advance our knowledge and maybe answer some of those questions that you brought up. So thank you so much for your time.
Thank you. Thank you for the invitation.
VEXAS may still be a new diagnosis, but it is already changing the way we think about some very challenging patients in our clinics. It's a reminder to step back when the pieces do not quite fit, when inflammation, cytopenias, and unusual multisystem disease may be telling one story instead of several. And it's a reminder that these patients do best when rheumatologists and hematologists are working together. However, we still need better evidence, better ways of stratifying risk, better data on which treatments work best and when to use them, and a clearer sense of which patients may need more aggressive approaches, like clone-directed therapy or transplant. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, let's try to get rid of those clones. And of course, stay healthy.
This podcast was edited by Resonate Recordings.